Hi, all. Welcome to an introduction to ketamine therapy for palliative care and end-of-life care, as I call it. Although I crafted this as an introduction, we're going to be talking about a lot of different stuff. And I actually developed this presentation out of training for the folks who are working on this at-home ketamine pilot. And then because we're launching a CME course, starts May 11th. It's integrating palliative care integrating ketamine therapy into palliative care. Then I thought this would be a great sort of pre-assignment. So if any of you have signed up for that CME course, great, thank you. And then this is your pre-assignment. So you'll cover two birds with one stone. All right. So having said that, I will get this going. All righty. So there's me again. So today I'm going to basically introduce ketamine. We're going to talk a little bit about the science. We'll talk about the ketamine research as it applies to palliative and hospice care, the protocols, routes of admission, and health considerations and contraindications. And then we'll speak about some applications in ketamine therapy for palliative and hospice care. And I would love it if anybody else on the call also is involved with programs related to ketamine therapy in this field. And then I'll wrap up with some client stories before we open it up for questions. So to launch right into it, ketamine was FDA approved in 1970 as an anesthetic. It's also an analgesic, made it very, very, very beneficial for a battlefield, and was used then in the Vietnam War and in subsequent wars since that time. Physicians found that soldiers who were administered ketamine had lower rates of depression, anxiety, and PTSD. So they knew that they were on to something. It wasn't until the 1990s, though, that we saw the off-label use of ketamine for both chronic pain and what we'll call mental health distress. It is now and has been on the list of the World Health Organization's essential medicines. Maybe many of you know that it's used in pediatric surgery. It's been used in the emergency room to calm people coming down. It's really a great sort of, again, anesthetic because it has a lower risk of respiratory depression, unlike other anesthetics. The tolerance, though, for ketamine can build depending on the frequency of use. And as we all, I'm sure, painfully are aware, it can be addictive and lethal in very high doses. So that's the major, major downside for ketamine, unlike other psychedelics. Ketamine uses, which as they're used off-label, not always reimbursable, unfortunately. And I've got a slide where we'll talk about that at the very end as well. So it is, though, very, very beneficial, has been proven beneficial for chronic neuropathic pain, unipolar and bipolar depression, anxiety, OCD, suicidal ideation, and we'll come back to that as well, addiction, migraine and cluster headaches, and PTSD. So today, though, we will focus more on the end of life, anxiety and depression, as well as spiritual or existential distress and grief. So for anybody that's not aware, this is a really cool chart. This is an oldie. Oh my gosh, this I don't know. This is from decades ago, I think. Dr. David Nutt had put this together to show the relative harms. And I think that little box is blocking it. But the darker color is the harm to others, and the lighter blue bar is the harm to users. So you see where ketamine is. Ketamine is about in the middle of the pack, but relative to alcohol, it's what, 1/3 of the danger in terms of harm to others and harm to self. So, it is relatively safe. We talk about it being addictive, but, quite frankly, I'm not sure of the rate of addiction. But it's still fairly low, obviously very low if used in a clinical setting, and people aren't using and abusing outside of the clinical setting. Why ketamine for palliative care? And we'll come back and visit this a few times, but as a dissociative anesthetic, your mind seems separate from your body. I love this photograph, so actually you're going to see it twice. And what that really means is it can put you in an observer mode, and you have an ability to sort of more objectively look at issues, which is also why it makes it useful for trauma processing. It has this propensity to help you die before you die. And I've got the study on a slide later on, but ketamine was ranked the most like a near-death experience. It's really great for palliative care because it manages pain, psychological, and existential distress. And as many of you know, if you can manage, say, the depression, you can manage better the pain. If you can manage the pain, you can manage the depression. So again, kind of like two birds with one stone. Also great because it has multiple routes of administration. I'm sure many of you know a lot of palliative or hospice care patients that are not able to take this medicine through the sublingual route, where they have to hold a sublingual lozenge or troche in their mouth for 15 or 20 minutes. So it can be administered via IV or intramuscular or rectally, transdermal, and topical. We'll talk about some of these later as well. And one of the other things I like about ketamine is that it's been proven safe for individuals first diagnosed, say, with a life-threatening illness, all the way to very, very close to the end of life. And I've got a couple of stories where the client basically passed within a week or two. Not planned, but they died within a week or two. So I wanted to throw this up, and this photograph, it makes me laugh whenever I see it, because I was trying to find an image of what my ketamine journeys were usually like. And I've had 12 ketamine journeys. 9 of them were IV, my preferred route, by the way, and 1 intramuscular and 2 sublingual troches. And every single time with the IV route, I would see these varying patterns that would just come across my field very quickly. They would pass through my field. And the colors would just keep rotating, keep changing, but the pattern was the same. And it looked like this is Monet's, I think, is it Monet or Renoir? Monet's Rouen Cathedral. And it just, when I found this, I go, yep, this is what I used to see, basically. But everybody's journey is not the same, and I try to capture some of what this is, keeping in mind that a ketamine journey is typically 45 to 60 minutes long. So there can be a feeling of dying, as I already mentioned. There can be a feeling of meeting with and chatting with loved ones who have passed. You can feel like you're floating just in total consciousness, not really going anywhere, but just feeling, within the universe. Some people relive ancestral trauma. Some people have absolutely nothing at all. There's darkness. It's black. It's like a black hole. They're not going into a black hole, but all they see is black. Very interesting. Some people cry. I certainly did on at least one occasion, all the way through. There can be thrashing. I've got a great story about a gentleman who thrashed for about 45 minutes. Some people want to chit chat. Some people don't want to talk at all. Some people are conscious of everything in the room. And then some people have frightening dissociation. So always a risk in terms of taking any psychoactive substance. So just to compare ketamine real quickly to some of the other major medicines that I look at when I talk about end of life care. So again, ketamine is a dissociative, but psilocybin, you do experience more of a unity consciousness feeling. It is definitely more somatic. Many people with cancer report confronting, chatting, dealing with their cancer somatically, sort of feeling where it is in the body, and then having an ability through guided visualizations to dissipate that cancer. So again, a very somatic type of experience, and a memory of holding that journey um, uh, in in the body. So that's psilocybin. MDMA, as many of you know, is less hallucinogenic. It works very differently than ketamine or psilocybin for that matter. It increases the activity in the prefrontal cortex. And so it makes, people are less hallucinogenic. It allows an individual with trauma to work through that trauma with a trained and skilled therapist. But why it's also really cool for end of life is that it's a heart opener. It can be used to deepen and repair relationships. It can be used to forgive self and others, and also to do a life review. So fingers crossed that MDMA gets FDA approval next time around, and it will become more available. Also wanted to mention, just because I find this really interesting, Sunstone Therapies, a research institution out of Rockville, Maryland, is doing an MDMA couples study where one of the dyad has a cancer diagnosis. The other individual can be spouse, significant other, or say adult child, undergoing the very same MDMA protocol to test it for the reason that I just said. MDMA has this propensity to really open the heart and have self and other compassion. Um, I love this slide too. This graphic. There's a lot on this graphic, I know, and I want you to pay attention to the orange because that is ketamine. So ketamine, relative to the two classical psychedelics here, there's LSD is the darker blue, and you can see at the very top where it says the imagery, LSD is almost off the chart, followed by psilocybin, and lower still is ketamine, with MDMA like the least likely to have these elementary images. But if you go around to the right there, clockwise, you'll see disembodiment. There's ketamine, right in the forefront. It's also kind of up there in terms of blissful state. I can definitely speak to that, where every single IV session I had, I felt that feeling of bliss, pure bliss. And I could see why it would be addictive, because it's unlike any feeling I've ever had before. So you continue sort of clockwise around that. It does provide insightfulness, as well as almost any of the other molecules. And then you look at sort of this audiovisual synesthesia. And again, I can test to this. I loved the ride, the blending of the audio with the visual, and felt that they were both enhanced by each other. So, and again, this is all relative, and you can shift this sort of spider web um, uh, analysis here by changing the dosage, but nonetheless, relatively speaking. So we'll get into a little bit more about how how the medicines work, and so again, looking at all of the medicines, or at least these 5 medicines here. Work that was done by Gul Dolan, so shout out to her, who was able to look at the opening of the social reward critical period. We're going to be talking a lot about neuroplasticity, and we all know as babies and as toddlers, we have this amazing ability to absorb information and to learn. And it's thought that psychedelics have that ability to open the social reward critical period for a time that is correlated with, you can either think of it as the acute subjective effects, which is the duration of, say, a psychedelic journey, to then how long that open social reward critical period remains open. So you can see here, ketamine is going to be on the far left because it is the shortest lasting journey for everybody, especially relative. You go all the way out to ibogaine, and you'll see that, I don't know, you can't, the bottom, I guess, got cut off, but that's 4 weeks. Oh yeah, it just says 4 weeks. And I guess I just was listening to somebody talking about ibogaine, and they said, yeah, they stopped looking. So whatever study they did, they took it out to 4 weeks. So it could definitely last even longer. But you see psilocybin, been looked at, it says 2 weeks here. I've also heard it lasting up to 3 weeks. This is why when we talk about ketamine, that it's best to have integration within 48 to 72 hours of a medicine session. That's not the only time you're doing integration, but to really kickstart it and try to catch that wave of the enhanced neuroplasticity to change thought and behavior patterns. So if I look at next, science. So we'll talk a little bit about this. I am a lay person, but I'll tell you, I absolutely love reading the research on this. So we'll talk about this because ketamine is so different, again, than the classical psychedelics. It operates on the NMDA receptor, and it creates a surge of glutamate. Glutamate is the most prolific neurotransmitter in the brain. I've seen it like 85 to 95% listed. It's an excitatory neurotransmitter. So it has this cascade effect where it's affecting a lot of other neurotransmitters, which is in turn going to help with the neuroplasticity. It is associated, glutamate, that is associated with cognition, memory, and mood. And it is a major contributor to increased synaptic genesis and neuronal plasticity. Again, thought to be key in antidepressant effect. And glutamate is responsible for balancing with GABA. And I think we all know that glutamate sort of excitatory, GABA is the exact opposite. So it's bringing people down as opposed to, in a good way, calming people down. But how it acts, and this is counterintuitive because we call it an NMDA antagonist, which basically means that ketamine is binding to the receptor because it's mimicking the receptor. It's got a similar sort of molecular structure. But in the case of ketamine and its action on the NMDA receptor, it is, as an antagonist, blocking it. And because, like I say, counterintuitively, it's actually releasing GABA neurons, then it creates a surge of glutamate. And then you have this marvelous cascading effect. And this is just one of the things we're going to talk about in terms of why neuroscientists believe that ketamine can help with anxiety and depression. So a couple of things going on, and I'll drop down to the bottom there. BDNF, the brain-derived neurotropic factor, is a major player in enhancing neuroplasticity, but there's some other things going on as well. There is what's called an AMPA receptor, which leads to track B, it's called, which leads to BDNF and mTOR. They're doing a little bit different things in terms of, one of them is building out those dendritic spines. You see those dendritic spines in that graphic on the right. Those are usually on the receiving end of the neuron. So they're receiving the amount of ketamine, and in this case, glutamate as it comes through the system. And so we're talking about neuroplasticity in a number of different ways. The dendritic spines, their volume can grow and it can create new dendritic spines. So all have an ability to build more glutamate through the system and able to have this cascading effect. mTOR, on the other hand, builds out and protects on reverses, as it says, synaptic damage. So the synapses, as many of us probably know from SSRIs, it's that gap between the presynaptic neuron and the receiving neuron. So again, this ability to reverse synaptic damage caused by chronic stress is just another really cool thing that ketamine can kick off. One of the other things we talk about a lot is how ketamine and psilocybin, and forgive me, I was trying to find a slide that had ketamine on it, but the effect is basically the same, where ketamine can quiet the default mode network. Now, why is that important? First of all, the network is made up of at least three major regions. Again, that prefrontal cortex, the posterior cingulate cortex, and the angular gyrus. And all of this can be very, very active when we are not focused. When we're doing a task, the default mode network quiets down. But it's important because for any of us with depression or anxiety, we have increased activity in this default mode network. For any of us who have repetitive, intrusive, negative, looping thoughts, it is increased in the default mode network. So again, the theory is if you can quiet the DMN, then you can get on top of those negative looping thoughts, which in turn really, really can help you deal with your anxiety and depression. So the third one I'll mention that I think is really important. So another effect that ketamine can drive is the role of the opioid receptors. In this case, it's the mu opioid receptors. And there was a study where one arm was ketamine alone, and the other arm was ketamine paired with naltrexone, which most of you have heard, used in opioid and substance use disorders. So naltrexone blocked the antidepressant effect in those individuals where it was paired with the ketamine. Interestingly enough, and this is just a shout out for why we need research done on both men and women, all genders, is because several years later, they found out that that was only true for males. It did not block the antidepressant effect on females. So just, note to self. Also wanted to mention then ketamine's mechanism of action that says pain management. As I mentioned, this is so critical when you're working with palliative care patients. So in this case, we're talking about neuropathic pain. So whether it's chronic regional pain syndrome or fibromyalgia, neuropathy, or trigeminal neuralgia, or other sort of neuropathic pain syndromes, then in that chronic pain, there is central sensitization. And what that means is that the number of NMDA receptors increases, which amplifies that pain. So ketamine can come along and again, blocking those NMDA receptors of the peripheral nerves so that pain transmission is intercepted before it reaches the spinal cord and the brain. So again, just so helpful for a lot of different things. But here's the net effect with everything that I just shared about how ketamine works in the brain, say vis-a-vis psilocybin or even MDMA. It is fast acting. It is incredibly useful for suicidal ideation. People have reported reductions or elimination of suicidal ideation within 24 or 48 hours. But as I mentioned, it's short lasting, which is why one of the gold standard, which I know has shifted a lot over the years, had been to give a series of loading or induction doses, typically 6 loading doses over a 2 or 3 week period of time, followed by maintenance boosters. So It's generally speaking not a one and done medicine. I will also say, I just wanted to make that point at the bottom, because I talk a lot about the fact that ketamine on its own is therapeutic. However, definitely agree, and the consensus is that psychotherapy, when paired with ketamine, can improve and sustain therapeutic outcomes. Now, a little bit about the research. I'm going to kind of quickly go over this because basically you can tell that the trend is downward, whether we're looking at depression or anxiety. Calls into question some of these trials, though, because the um, uh, the studies weren't set up to be that strict. So in one of the studies, some were using oral, some were using intranasal, and then they still compared them. In the case of the uh, study on the right, many of you probably know Scott Irwin. He did a lot of work in this field. And so this is an oldie but a goodie as well. But when you're working with hospice patients, what are they started with, I think, 12 patients. Within a month's time, they were down to 8 patients who actually finished the study. So it speaks to the need and why, we're calling this ketamine therapy for palliative care, because we really want to catch the people much earlier in their disease progression. I liked this study because this was a literature review, and it did reinforce the fact that the most effective, it thought, and convenient, really important too, for treating depression was to receive in clinic either IV or IM, followed by maintenance with in-home troches, sublingual troches, once they've been trained. So another more recent study that came out of Canada. So again, you can see the trend there of it. I wanted to mention this. This is in a rat model, mice models, animal model for sure. And they were looking at if ketamine could reduce levodopa-induced dyskinesia in Parkinson's patients. And that is what they found, essentially. There is a company called PharmaTher who actually conducted a study in humans. And very interesting, they had a press release where they had top line results. And then when I looked, and this was like several years ago, like 2022, and when I went and looked for the actual publication, no publication. Clinicaltrials.gov reports it as like having an unknown status. So I don't know what the heck to happen to the human subject study, but I certainly hope that somebody takes that up again. As I mentioned, this is a retrospective study where they took some 15,000 reports of experiences with 165 psychoactive substances. I mean, that's kind of interesting just by itself, 165. And compared them to 625 descriptions of near-death experiences. And they found, yes, that ketamine was most like dying before you die. And I actually got a case story where there was this woman with end-stage cancer who, through her practice, I will call it, with ketamine, was able to set her intention to go beyond and chit chat with loved ones who've passed during her ketamine journey and then come back. And she was able to successfully do that routinely. So I'm going to shift gears a little bit and talk about routes of administration. And these are the major routes of administration. And like I said, lots of flexibility and lots of reasons why you would choose one over the other. As I said up front, I'm a fan of IV because we were able to kind of raise or lower that rate of ketamine. Important to note that, especially relative to other routes, is the bioavailability. All of the ketamine gets into your system versus some of the other ones where it doesn't. At the risk of folks who prescribe, what I have seen is dosing ranging from 0.5 milligrams per kilogram. Generally speaking, physicians, prescribers start with a weight-based dose. don't always stay that way because it's found that it's not necessarily a weight-based medication for efficacy. And some prescribers will go up to 1.5 or 2 milligrams per kilogram. I was a 2 milligram per kilogram person, I think, because I take lamotrigine. I already mentioned this sort of induction doses and the need for maintenance boosters. Potentially, I haven't had a booster in a couple of years. So, not everybody, but some people, depending on their condition, may need a maintenance booster. And hopefully what happens is, even if you start out requiring a booster every 4 weeks, that over time you can prolong that period between boosters. And this is true for either IV or intramuscular. I do want to mention, because I find this to be fascinating, because we do get into these discussions about dosing. That's my doctor. That's my doctor from Sarasota, Dr. Reichbach. And I have a case study about the woman who introduced me to Dr. Reichbach, and I in turn introduced him to a friend of mine in Sarasota, a woman who had undergone dozens of electroconvulsive therapy treatments, dozens, had been institutionalized at least 3 times, was on a lot of meds, which I'm sorry, I don't have the list of those meds. She literally required 7 milligrams per kilogram. And I know that's probably unbelievable, but she also, 45-minute journey, she remained conscious. She got up after the 45 minutes and she was able to leave. Most of us, after a ketamine journey, need to rest. I need to rest for at least another hour, and I'm still kind of woozy. So it just shows you the incredible range that it sometimes requires to actually get to a therapeutic benefit. So this is the pain management protocol, and so it's vastly different. So I had like 110 milligrams over this 45, 60-minute period of time. A pain management protocol may start at 1 milligram per kilogram per hour over 3 or 4 hours. So, or 100 milligrams per hour. So that could be 300 or 400 milligrams administered, or it can be titrated. So the same doctor that I had, my doctor, he was telling me that some of his patients get 1,200 milligrams of ketamine over a 4-hour period of time. So you can see those doses are on an order of magnitude higher. The good news is if you have depression or anxiety and you're using ketamine for pain therapy, it will handle the mental health as well. There's a couple of sample protocols here, not by any stretch of the imagination the only way that ketamine for pain is administered. And then some folks then will come back and have 2 to 3 booster sessions as needed, like when I say back to back, 3 subsequent days. And then maintenance is prescribed at home. Sublingual troches can be up to 3 times a day, and sometimes it's just PRN. It's up to the individual. I am sort of similar to IV in the sense of bioavailability. Typical starting dose, very similar. The big difference is that a lot of times intramuscular injections are used or are administered 20 minutes apart, and that's broken into whatever the prescriber and you decide. Maintenance boosters may also be needed. So both IV and IM, I would say, are really great for moderate to severe mental distress. And then, but we look at Spravato, also potentially for moderate to severe, although it's been shown that Spravato does not perform as well as ketamine. And Spravato it goes by the name, it's S-ketamine. Some molecular structures have mirror images. I don't know if you can see my hands, but mirror image like your hand. So not all molecular structures, but ketamine does. and they don't operate the same. So there's an S-ketamine mirror, and then there's the R-ketamine. Well, the S-ketamine provides less dissociation, but higher NMDA receptor activity. There is a standard dose. This was FDA approved. So the good news is that some insurances will cover it, some will not. You have to check with your insurance. And I always say, if you're looking to do ketamine and your insurance covers it, go the Spravato route. And if it doesn't work, then look to other routes of administration that can go higher, because as you see here, the bioavailability is half at most of an IV at most. And, sometimes the nasal spray ends up dribbling down the back of your throat and you don't get all of the medicine. It has to be administered in approved clinics. And you see that cost there. This was a Johnson & Johnson company, Janssen, that developed this medicine. And yeah, they get paid pretty well for it. Here's the sublingual, either called troches, or sometimes we call them lozenges, or they can be in the form of more rapidly dissolving tablets. Again, held under the tongue so that the bioavailability, again, because you lose a lot of it not being absorbed under the tongue, then the bioavailability is at most 30%. And I've seen more numbers, more like 17, 20%. So definitely something to consider, and which is why the dosing can be typically between 100 and 600 milligram. Some folks will remember this. Just heard a story yesterday. I think that person's here, that was prescribed a 600 milligram dose and was told to swallow. Many of you probably know that the telehealth medicine companies now require to the extent they can, that people hold the troche for 15, 20 minutes, or the RDT, and swish and spit out, because the effects of the ketamine can last a very long time. In this case, it was a 6-hour journey, which was not pleasant. I know when I tried troches twice. Once I spit, once I swallowed, and it was like 3 hours before I could actually get up and be functional again. So it's like, I ain't doing that again. Can also be used rectally. People use these lozenges rectally, if they're not able to hold the troches in their mouth for that period of time. There is what's called a psycholytic dose that many psychotherapists use. And that means that it's a lower dose where the therapist and the client can talk, and it in the sort of IFS parlance softens the parts and can enhance psychotherapy. And as I mentioned before, it can be prescribed for pain and mental health to prolong sort of the duration of benefits between the infusions and injections. So I don't know why this happened and I didn't have time to change it. So potential side effects. So elevated blood pressure during the session, or heart rate. There can be nausea or vomiting. Always be prepared for vomiting. Interestingly enough, a person can become drowsy or have insomnia, not be able to sleep that evening. Also, stories of pain or anxiety flares that can continue for days after the session. It calms down eventually, but nonetheless, there is the potential for these pain or anxiety spikes. Constipation, it is an anesthetic. Cystitis, the way that ketamine works on the bladder, it can cause urinary tract infections or cystitis. Urinary tract infection-like symptoms like cystitis can cause frightening hallucinations, and it can cause problems with concentration. So contraindications, and many of these are relative. So when you see these listed here, it's really up to the doctor. Some of these are absolute contraindications, but uncontrolled high blood pressure, severe heart disease, up to the prescribing physician to decide. But uncontrolled seizures or severe asthma, severe liver or kidney issues, apnea, an aneurysm, recent heart attacks or stroke. So then, just like all the other psychedelics, we speak in terms of active psychosis. So the manic phase of bipolar, schizophrenia, borderline personality disorder, in part because it's very difficult to build any kind of therapeutic alliance with a person with a personality disorder, and ruled out typically as an active substance use disorder. So you see some of the other ones there as well, that again, up to work on with your physician in terms of what is relative, what is absolute. I'd say pregnant is absolute. The elevated cerebrospinal fluid or intracranial pressure, because ketamine can increase that. Uncontrolled glaucoma, similar as well. And then you look at health conditions that may block the efficacy, and so things like hypothyroidism or low testosterone. Managing side effects. So you physicians or nurse practitioners have a lot of tricks up your sleeve in terms of what happens during a journey and what you recommend pre or post session. So lots of things that can be used for nausea. I know I always got Zofran, the brand name, in my IV, but there's other forms that you can take. And then post session, sometimes people are prescribed Zofran again, but things like Benadryl can be helpful. And then for anxiety, although Versed as a benzodiazepam, it blunts the effects of ketamine. So, your prescriber decides the cost, the trade-off there in terms of providing Versed versus the potential loss of efficacy. Brain tap, some of you know Dave Dansky. He talks about using brain tap. So they're goggles that, I don't know if it's binaural beats, that can calm a person down. And he uses that pre-session and says it has reduced his need to use Versed to nothing, at least at the point in time he said that. A lot of us like to use magnesium L-threonate for calming routinely, not just post-session. That form of magnesium is about the only one that crosses the blood-brain barrier, which is why it's most useful. Headaches may be rarer, but sometimes people can have severe headaches, and physicians can prescribe Toradol for that. Also, we tell people then drink a lot of water. You can drink caffeine, take Tylenol. Constipation, this can be a problem, as I mentioned. So you may want to use a stool softener, especially if you're in that period of doing the induction or loading doses, because that's a lot of ketamine over a 2 or 3 week period of time. So there's also then ways to handle increased blood pressure during the journey. There is a bladder protocol that I have from Kimberly Jurowski, and it was actually updated a little bit by David Dansky, and I can make that available to anybody who wants it. And then if there is respiratory distress, like I say, ketamine is a low risk, but if there is, then there is albuterol or a bronchodilator as a possibility. Okay, so drug interactions. The good news is that there are less interactions with the psychotropics, the antidepressant type of medications than, say, psilocybin and LSD, certainly ayahuasca. But because of the way it works, like I say, differently than the other molecules, these may increase the effectiveness of ketamine. So lithium for psilocybin can increase the risk of seizures. So big difference. SSRIs, oxytocin is sometimes provided, sometimes given in the IV, actually. Dextromethorphan, interestingly enough, that's what's is in your cough medicine. And I've known people who will buy Robitussin and use it following ketamine sessions because it's believed to help prolong the benefit. Because of the way ketamine works on the liver, there are things that are the inhibitors of this CYP3A4, like grapefruit juice. So interesting to note. And then you've got the reverse, things that reduce effectiveness. And as I mentioned, I'm on Lamictal, and hence that's why I needed, I think I needed more ketamine. Also, doctors or your prescribers will ask you to hold the doses of some of these, like your benzos, like gabapentin. And then the flip side of the inhibitors, you've got the inducers. So something like St. John's wort, which people sometimes use as a supplement, can actually reduce the effectiveness of ketamine as well. So anything that depresses the central nervous system obviously is not good. Anything that is a vasopressin, which constricts the blood flow, not good, as well as you can imagine, amphetamines, cocaine, ADHD meds also asked to be held. Note of caution. So nobody studied the long-term use of ketamine. I already mentioned the possibility of addiction or tolerance buildup, the potential for the interstitial cystitis. Seen more in pain patients or in recreational users using ketamine at high doses. And this was cool. Some of you might know Raquel Bennett, who founded the Psyche Google group, and I actually have a link for that for anybody who wants to join. Neuroplasticity only goes so far. She had made mention that for Alzheimer's patients, early Alzheimer patients, no amount of ketamine is going to repair a damaged neuron. So just something to keep in mind as well. So now I'll switch over. And thank you so much for bearing with me, because I know hopefully I'm not talking too fast. So, ketamine has been long used in palliative and hospice care. It's been used for refractory pain, for severe agitation at end of life, post-operative use, as you see there, to reduce the need for opioids. And now, as we know, we've already talked about anxiety and depression, chronic pain, but let's talk a little bit about existential and spiritual distress, grief, and supporting medical aid in dying. So I guess, I'll start here with spiritual and existential distress. I wanted to first define spirituality because because of the work I've been doing lately, which I'll mention in a moment, been thinking, well, really, what is spirituality? And this was a definition that was born out of a chaplain conference, and they came to consensus that it's the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to self, to others, to nature, and to the significant or sacred. So a really broad definition that we know applies to people facing a terminal illness, facing a life-threatening illness. Existential distress then basically can mean a loss of meaning and purpose, feelings of worthlessness, hopelessness, and loneliness. And I want to say that, this is a separate phenomenon, because some people can have existential distress and not depression. Some people can have depression and not existential distress. So it's something to continue to talk to or sound out your patient or client for, in terms of really what are some of the things that they are facing. And what we really know, which is so cool, is that spiritual care now is understood to be an important intervention in palliative and hospice care. So, this awareness that this needs to be part of the care, which, by logic extends to something like ketamine therapy. And again, as I already had mentioned, ketamine, great for a sort of dress rehearsal for death, to help individuals overcome their fear of dying. Or in the case of some people, um, enjoy the other side and get a sense of what beyond might look like. So I wanted to give a shout out to a couple of programs here that you may or may not be familiar with. So Dr. Rob Horowitz and team launched a ketamine-assisted psychotherapy palliative care program. Is a psychospiritual program. They launched this in 2023 at the University of Rochester. It was an interdisciplinary team that included physicians, nurses, therapists, and chaplains. And for a 2-year period of time, they treated 59 patients. You see there, their ketamine dose averaged 0.93 milligrams per kilogram. It was delivered intramuscularly. There were minor adverse effects and no serious adverse events. And the facilitators were paired. So it was the prescribing physician and a therapist or a chaplain or a nurse accompanied them. And they had one preparation session and one integration session, although patients could, and some of them did opt for multiple ketamine sessions. So this work is ongoing, somebody to, connect with if you're interested in doing similar work. Now, I don't know if she was here. Jennifer Johnson, if you're here, I actually would like you to raise your hand when I'm done talking, because Red Willow Hospice, along with EOLPC, were both awarded grants through Healing Hearts, Changing Minds. And so Red Willow Hospice, headquartered in Taos, New Mexico, is working on, I loved how the executive director phrased it, a mind, body, spirit program. So key goal, located in New Mexico, is expanding access to rural areas. So this is just so needed, I think. And that is also an interdisciplinary team, and I'm anxious to hear more. This is just kicking off. We received funding in December of 2025. And so all of us are just in the process of kicking off these programs. So speaking of which, ULPC is collaborating with the Institute for Rural Psychedelic Care that was co-founded by Michael Fratkin. Most of you know him. He is a palliative medicine physician. And Legare, a Christian psychedelic society founded by Hunt Priest. So we have developed a spiritual model. We are pairing a palliative medicine physician with a chaplain in 3 sites. So Michael in Humboldt County, California, Dr. Gail Bereskin in Chicago, and Dr. Sharika Newman in Atlanta. So they'll be paired with either a doula, a chaplain, or a minister. And I've been doing a lot of training as part of this, which hence again, this is where this presentation was developed. So the overview of our protocol is we will conduct obviously an intake and medical screening. We have 2 preparation sessions. There's 3 medicine sessions, and following each medicine session are 2 more. We're calling them meaning-making sessions. Our dosing, this was the protocol that Michael's been using with his patients, 0.7 milligrams up to 0.8 with a booster if desired. Okay, I want to mention ketamine and grief processing. So one of the great things about ketamine, one of the many things here about ketamine, it can disrupt the rigid thought patterns, kind of what we talked about before, negative looping thoughts, applicable to grief loops. As I said, this sort of dissociative effect of putting yourself into an observer mode enables that detached perspective to observe painful memories and find emotional release when working with a trained therapist, can then help integrate the loss. And this typical protocol is more the psycholytical dose that I was talking about. So the sublingual troches, and in conjunction with a trained grief therapist. So I think something really important to keep in mind. And I know 3 grief therapists, if anybody wants a referral. One's in New York, one's in Olympia, Washington, and one's in Portland, Oregon. And I know that there's a lot more, but those are 3 that I know of. And then ketamine and medical aid in dying. And I should say, first off, I am not recommending ketamine use just prior to medical aid in dying or even in conjunction with. But anecdotally, we know that people have used psychedelics to determine if they're going to use medical aid in dying or if they're going to just forego it and say, no, I'm good with my life. I've got a great story, a great psilocybin story about that. A gentleman who is living with quadriplegia now for about 32 years. And he turned to psilocybin when he got to a point where the pain was so great, he just wanted to die. He's had several psilocybin journeys. New lease on life, met a woman, fell in love, has no desire to die. And medical aid in dying currently is legal in 12 states and the District of Columbia. Of course, we know about the program in Switzerland there was an individual that just went who had Alzheimer's. And what I got from his wife was that he had put the voluntary aid in dying into his advance directive when he was still could provide informed consent. So that was interesting. And Canada, it is legal throughout the country. So I wanted to end with this, and I think I forgot something here. But anyway, the bad news is that so few insurance companies will reimburse for ketamine therapy, and I almost consider it criminal that many of them don't even reimburse for pain management. Kimberly Jorvieski, the same person who developed that bladder protocol, founded the ketamine task force, and they've been working for a long time to try and get at least Medicare to cover it, and then still banging away at it. A few insurance companies will reimburse for mental health distress. Providers, as many of you know, can bill insurance companies for the medical eval, for the preparation and integration sessions, assuming it's a licensed clinician that is delivering the services. A patient can submit a super bill and be partially reimbursed. I have the CPT codes if anybody wants them. I can share them as well. I got a whopping $30 per ketamine session, which was costing me $500 per session. So, up to the insurance companies to how much can actually be reimbursed. But that can be in addition to having a therapist, submit for reimbursement for you for a preparation or integration session. I already said some insurances will cover Spravato, thank goodness. But there's also one of the things that we're working with Michael so that we can better understand it. He works with VA, some ketamine clinics become VA community partners and can offer ketamine therapy to veterans. There's also PACE. What's that? That's a federal program, and I'm always spacing on what PACE stands for. But it does provide federal funding for older adults, and Michael has successfully used that to fund some of his patients, as well as he gets hospice referrals. So there are avenues, albeit limited at this point in time. So one more thing, and then I'll stop. So I wanted to share some of these stories because it's in the telling of the stories that I think it really hits home. So Patty is my friend that I mentioned. I was referred to Dr. Reichbach, and it was by her. She was diagnosed with stage 4 head and neck cancer. This was in 2016. Because of that diagnosis, she suffered from such debilitating depression, she did not want to leave her home. She was given that series of loading doses. After just one session, she felt her mood lift. After the 6th session, she felt joy. She went out and found a job. that she holds until today, through today. Currently, so she does continue booster sessions. She was spacing them out 4, then 6, then 8 weeks, and then started taking the sublingual lozenges in the home, PRN, which she used rarely. And by the way, because she had head and neck cancer, you'll see this next bullet there. She started to, she had trigeminal neuralgia. The radiation killed the cells in the tissue in her jaw, and she had tremendous pain. And she also was suffering from neuropathy. So she went back to Dr. Reichbach, got higher dose ketamine infusions, and uses the sublingual lozenges rectally. Last I heard, she was using them like once every other week, and so she's able to manage her pain and maintain her job. This is the ALS patient, max transfer assist, so pretty advanced stage ALS. This is Michael's patient. Michael explained the risk of dying and both consented. This is an example of where Michael's dosing was 0.7 milligrams per kilogram with I think it was a 15 milligram booster. And during this gentleman's first session, he visualized himself sort of free of the shackles of his body, running and playing with his children. And he was filled with contentment. That release from his physical body brought him contentment. The second session, and Michael usually does 3 sessions, and that is our protocol as well for the pilot. He brought his hands together in a posture of gratitude, and that's what he spoke to Michael about afterwards. So it was a coming to peace with his life and being grateful for his life as it was. And even though, for this gentleman, ketamine came very late, and he passed before Michael was to deliver his 3rd session, but he passed peacefully in his sleep. So even though, like I said, it was late in coming, it did bring him some peace. John is a gentleman who is an example of using medical aid in dying to gain clarity on using the medical aid in dying. This was a gentleman, you'll see that first bullet point there. His pain levels were a 9 to 10 on a routine basis, and he wanted to die. He wanted out of this. He was a gentleman who had inflicted trauma on people. And this, during the first session, came roaring out. He was shaking, he was yelling, he was thrashing for just about the full journey. But when he came out of the journey, he calmly discussed it and could discuss it openly. And even though he relived his experience. And so next day, he felt less burdened by his shame, and that stayed with him. His pain level the next day, at least, was reduced to a 2 to 3. His second and third sessions was where he wanted to gain clarity on the medical aid in dying, and he did. And then in that last ketamine session, he brought completion to the relationship with his son, and he passed away on June 2nd. This would have been 2024. I love this story because this shows that ketamine is not always great, and I don't have enough stories where sometimes ketamine it provides a challenging journey, or sometimes doesn't even help at all. So this was a story that some of you might know, Dr. Fee in New Zealand. She told the story about a 28-year-old married with young children who was diagnosed, and it was now metastasized. So Dr. Fee administered 4 at-home ketamine sessions. And the first one, it was beautiful. It was a communion basically between her cancer and her body. It released a lot of anger. The second one, she set her intention for a near-death experience, and she felt she did. She was standing under a waterfall with just infinite stream of light streaming over her. However, between the second and third sessions, her pain worsened. And as an example, she was prescribed a fentanyl drip. So she was on the fentanyl drip. She received her third session, she felt her soul leave her body, and it was also a very, very comforting, where her kitty cat laid on her chest the whole time, and she just derived a lot of comfort from that. But her fourth and last session was um, was challenging. I'll put it that way. She felt trapped in her body and felt deep sorrow, and she sobbed for the whole time of the ketamine journey. So she did feel ultimately that it allowed her to grieve more deeply. So this Jehan is the attorney that I mentioned. She's the one, she was a psychonaut, total psychonaut. But when she told her story, she was participating in ketamine sessions twice per week because she had been diagnosed with bone cancer that had metastasized. So she routinely set her intention, as I say, initially how to be with what is, and then expanded to die before you die. Do I have? Yeah, I'll tell this story real quick because this woman would be dead if it wasn't for ketamine. So, 74-year-old suffering from severe depression, and another one with very severe pain. She lost her will to live, and she, on her own, began a voluntary stopping eating and drinking regimen. Her son, on a visit, said, "Oh no," and involved hospice. And so she's an example where she was actually treated on an inpatient basis with a 5-day drip. She was discharged from hospice. At discharge, she was prescribed the at-home sublingual lozenges 3 times a day. And she now used her oxycodone, which she depended on before, sparingly. The doctors decided to then take her off the oxycodone and prescribe methadone for her, and she still was taking the sublingual lozenges. And this was follow up again when the story was being told. After 6 weeks, she was back to being active in her community. So just an amazing story. Um, you will get these slides, so you will see these resources for those of you who aren't part of Michael Fratkin's and Jackie Smith's palliative care psychedelic therapy Google group. I encourage you to join. There's that Psyche Raquel Bennett's group. That one, I have to say, is very active, very, very active. Lots of questions get asked and lots of good answers. So Hunt Priest, I had mentioned Ligare Christian Psychedelic Society, really a great support group. And then there's the Shefa Jewish Psychedelic Support group as well. And then I have a lot of resources for anyone who is experiencing the terminal illness or cancer or is in remission. We have an online support group for those individuals. So reach out. You all will have my email by now, so you can reach out. And so, oh gosh, how many are left? Oh, thank you. Y'all didn't leave. Um, yeah. Okay, so we got some time left for questions or shares. I first want to ask, is Jennifer Jones, Jennifer Jones, yeah, Jennifer Johnson, or anybody affiliated um with ah yeah, you're
Hi.
here.
Hi, Chris. I'm so sorry I got on late. I got my wires crossed about the time, and so I was in another meeting.
Did you hear me give you a shout out?
I didn't. I'm like, but a friend of mine texted me, and so I hopped on.
Yeah. So yeah, I would love for you to share a little bit more because I was talking about, programs that I knew of. So I mentioned the one that we're doing. I hope I get to see you in Madison. But anyway, uh yeah. So can you
No,
just
I'm not. I'm not going to that. Yeah, to the
oh,
Usona.
bummer.
No, I'm not. I'm
Okay.
not doing that one.
So yeah, but go ahead. Just give a real quick overview of your program. And again, Jennifer's she's the RN clinical director at Red Willow Hospice in New Mexico.
Okay, thank you. So I don't know if Chris said this, but we were the recipients of a grant from a foundation called Healing Hearts, Changing Minds to develop psychedelic end of life care in hospice. And so, just really briefly, we're going to integrate it into our normal hospice structure. looking at structuring it very similarly to how we structure MAID. So the process of admission and assessment and consenting process that we do for MAID. I don't know if I need to expand on that, Chris. Yeah.
No, that's good.
And we're going to begin with ketamine service. This will be in home. We have a few, we have several patients in facilities, but I do not know that we will be able to do the service in facilities. So that's kind of more to be determined. So starting at in-home care, we'll start with ketamine, and then once the psilocybin pathway is cemented in, we're going to add the psilocybin in. We as a company are training our staff. We're in a couple different trainings for ketamine and psilocybin, and kind of building that out with our existing hospice structure, which is really supportive of, this structure. We have spiritual care coordinators, social workers, therapists, volunteer staff, that includes doulas, and medical oversight. So yeah, is that a good overview, Chris?
That's good. And then if anybody has any questions, feel free to ask for Jennifer. As I mentioned up front, we were going to keep the video off, but you are very welcome now to bring your video back on, and I hope you do, because I'd love to see your lovely faces. Yeah. Okay, Tim.
Hi, thank you. Great talk. I've got two questions for you. A little background about me is I do own and operate a ketamine clinic in Omaha, Nebraska, of all places. And then my first question is regarding addiction, the potential for addiction to ketamine. And I've got some thoughts about that, but like I was wondering if you could like explain a little bit more about how you feel it's addictive.
Um, Boy, I would like to hit up Rob Cole over there. You have some ketamine docs here that, are really well versed in it. I am going to say one thing, and then Rob, I would love you to chime in. I'm talking specifically about palliative and hospice care. So I will tell you, personal opinion only, that when you're dealing with somebody who's closer to end of life, that the addiction potential is to be discussed, and it's a risk that somebody needs to decide.
Yeah, okay. Well, I guess I'll bounce out of that question, but I'll come back to it in a different way. Um, I was looking at using ketamine in the palliative care space and talked to a couple different hospice groups here in Nebraska. And because many of the clients are falling into Medicare, Medicaid, they have a protocol which they're asking to work all the way, like empty the bag of morphine, and then you can use an adjunct. Um, and I have thoughts about that. Like, I feel like by if we were to use ketamine on top of morphine, I feel like there's a really high potential for the client to go into respiratory distress from the morphine because now they are out of body, pain's relatively taken care of, and now the unwanted side effect of respiratory depression kicks in. Is that Have you had any thoughts about that?
As a non-medical person, no. Does any physician on here would like to answer Tim's question?
I my only comment is that the simultaneous use of high doses of morphine and ketamine together, that's an unusual clinical situation. I'm not
Yeah.
aware of that happening. I think there's some certain situations when you're in a terrible feedback loop with um, a specific pain situation that maybe both would be used, but I've not had
Like my
any.
mother. You have your wallet,
Yeah.
you have your glasses, you have keys.
Uh, yeah.
So I don't think I can really comment on that. Overall, my experience is that the likelihood of addiction, I think, is very low in a controlled situation where the patient is being administered medications in conjunction with the therapist or a physician. So we're really clear about how often the medication is being used.
Yeah, I
They,
like that. I like that.
this, I'm
I
going to
would,
have Tim, hold on one second. Stephanie, I was calling on you next anyway. So we have another palliative medicine physician. And thank you, Rob, for that response.
Hi, and I was a little bit spacing out. Excuse me. I was talking, or I was doing, I was looking up some stuff. I've loved this talk. So informative. Thank you. Great cases. Sometimes ketamine, hospice patients often are on big doses of opiates, and this whole topic of how we really have to look at the combinations that and anticipated side effects. And sometimes, if a person is on a respiratory depressant, they really may need monitoring that is beyond the capability of a home practitioner or even a clinic. And my introduction to ketamine was people being admitted from hospice directly to the hospital for ketamine administration for pain relief. And sometimes it requires higher doses of, or just higher monitoring, bottom line. If there's, and opiates are very strong respiratory depressants. In my experience, it's really hard to predict who's going to have those first few minutes of, it's almost like an apnea for I don't know how when you're doing it at home, it can be, you're like, wow, you want to do a little sternal rub, you want them to take that breath. So I think having a healthy dose of anticipating side effects is important for any practitioner. They're very uncommon. And like Rob, I would say, they're in the patient selection. Somebody who's on high dose of opiates would be a consideration, but at this stage of ketamine use and end of life care, those cases are still pretty low, I would say. And you can always do
So,
low doses of ketamine. That's what I really like about it. Like a talkie dose, like a 0.5 milligram IM,
Mhm.
would be a way to deal with that, is like start low and just see whatever metric you're following for the therapy, see what low dose might be able to create space for that patient to explore whatever they want to explore.
Yeah,
if I
I
could
like that.
jump, if I could jump on that, in the hospital setting, hey Steph, I've had patients on high dose dilaudid PCAs with basal and at PRN who have had ketamine infusions on top of that. And those were usually long infusions, about 6 hours. Um, Granted, being in the hospital setting, they were down in the PACU, they were being observed during that time. Um, we've never had to do intubations on those patients, if that says anything. I've
Yeah.
also used ketamine, lower doses, because this was more for pain in the hospice population. And this one patient I'm thinking about, she was on methadone on top of Dilaudid. We were just throwing everything but the kitchen sink at her because she was having such severe pain. And so we added the ketamine. And again, this was before we were talking about CAP, so I wasn't doing it for this. I was doing it for her pain, but she probably had some existential stuff that was addressed with the ketamine. But again, this was at home. She didn't have any issues with it. And then the other thing is when you're doing hospice, you tend to have that conversation with the patient, and they understand that there's a potential for this to maybe increase or kind of progress things along a little bit faster. But usually we have that conversation when we're getting to that conversation, just like you would with palliative sedation. Um, so, I mean, those would be my 2 cents, though it's not why my hand is raised, but we can do that.
Thanks. That does hit regarding ketamine on top of high dose morphine and not having to intubate. So the addiction, back to the addiction thing real quick. When I have clients in my office and I'm talking and going through a consultation, addiction does come up because of Matthew Perry and blah, blah, blah. I pretty much pivot away from bodily addiction, like opiates and alcohol and things like that, where you feel the addiction and it goes away only when you reuse. And I kind of go into a cognitive addiction. Does anybody else see it that way? Like potentially the escape from reality is the addiction, not necessarily like addiction like opiates or hardcore addiction drugs like cocaine or whatever.
I want to just add in my 2 cents. Prior to hospice, I specialized in addiction. And towards the end of like a 7-year stretch of specializing in addiction, I started to see people coming in to detox off of ketamine. So I agree with you with the cognitive piece. Like, really, they're just used to being in that state and they get addicted to that. But there is also a physiological withdrawal that happens. And so we would have to figure out how to address that. And it was a really new thing. So that's just my small experience with that. So there is a little bit of a physiological that I observed.
Cool. And you have a question too, Christine?
No, I'm good.
Oh,
Okay.
yeah. Oh, okay.
Yes, thank you. I wanted to ask in regards to policy. So I am now in Georgia, and Georgia is putting together a policy. I'm a physician, palliative care, hospice, and have also had the CAP training through IPI. And Georgia is looking to limit the ability to do ketamine to only anesthesiologists, nurse anesthetists, and nurse practitioners trained in that. So essentially, making sure that you are in a clinic setting or in a hospital setting when my goal would be more to do home-based, as we do with hospice patients. As it is, I do home visits. So I'm just not sure, do we have any kind of people working on the policy aspect of things?
Do you know Sharika Newman?
I know her by name. I don't know her personally, but she has a clinic, so I don't think is she doing them? And this is a new thing that they're looking to pass.
Yeah, I know.
Because
She was, it seems to me she was like at a public comment meeting. There was, and I meet so many people I forget. There was a gentleman, because we talked about Sharika being there. So there are people that are speaking up at the state level. Yeah, so I can put you in touch with them if you would like.
okay.
See,
Yeah, then I'll reach out to you separately then. Okay.
yeah, cool.
Thank you.
Thank you. Audrey, is Audrey still here? You had a question earlier you put in the chat. Maybe she had to leave. Oh yeah, there you are. Yeah, ask your question, Audrey.
Not sure if you can see me.
Yeah, can see you now.
Oh, okay, cool. Okay, so I was reading a very interesting article by Midwestern doctor on DMSO and its neuroprotective effects. And I had a ketamine patient today. I said, right, let's just, massage some DMSO and castor oil, which I have for my arthritis patients. I said, let's massage that into your sore leg and massage that into your other leg. See if the transdermal DMSO can potentiate the ketamine. And he said afterwards that he definitely did have a much more intense journey. So I was wondering what you think of combining DMSO and ketamine together, possibly. And NAD also, sometimes if somebody seems very depleted, then I might give them a little bit of NAD in their ketamine infusion. And it does that also seems to work very nicely, especially with like Alzheimer's patients and people with brain fog, just to almost improve the metabolism of the brain. Do you have any thoughts on either of those two, DMSO or NAD?
I'm going to look to Stephanie. You can't ask a question. You're going to ask a question. You're going to answer it yourself. But no, can you or Rob or somebody else like answer Audrey's question? I've told you everything I know about ketamine. So
I can't. I don't have experience with doing that, though. I'm always intrigued, and this is where the lack of data gets so frustrating. But I can't. I don't have direct experience with.
Rob, do you?
No, I don't. I don't have experience of it. It's an interest. Theoretically, it's a great idea. I think lots of people have had success with topical ketamine for certainly pain management, and but I have no experience with it.
So this
No,
is what
this
you need to
wasn't
do,
topic.
Audrey. Audrey, this is what you need to do. I'm providing the 2 links to the Google group, and Psyche, I think, like I said, it's really active. And join the group and put your question there. You'll get answers. I can
Fantastic.
guarantee you.
Thank you very much.
Yeah, you're welcome.
I've seen NAD post psilocybin really help. So, and that was again for the depletion. So I'm assuming that the ketamine would be similar potentially. But
Yeah,
again, I'm not seeing, there's no real
it
literature that I'm
was,
seeing at
yeah.
this point.
It was a very interesting case that I had with this old man with Alzheimer's, that his daughter brought him in for a vitamin infusion, and I said, well, since he's anxious and depressed as well, can I add some ketamine as well? And he actually got his sense of humor back, and he was able to have a conversation and understand jokes, and he was back. It was really cool. And just sort of also an aside, I gave ketamine to a little kid. So I'm a GP, and I figure since I've been doing ketamines, I've been giving people ketamine since 5th year medical school in the ER for like stab chest, and you need to intubate this guy, right? Tiny little microdoses in a controlled clinical environment obviously are fine. And in South Africa, we have a lot less legal problems than in the first world. So I gave this little kiddie of, I think he was 4 years old and he's autistic, a ketamine dose intramuscular at a sedation dose so that I could draw blood for other problems that he was having because he had severe anxiety. We made sure that he had a nice journey. He sat in his mom's arms. She sang to him. We played him all his favorite music. And now 2 years later, I saw him again, and his social skills are better than his mom's. And he's had an improvement in eye contact, an improvement in verbal communication with other people. And it was just really cool and interesting that ketamine has also improved autistic symptoms in more than just this little kid, but it had a really long-lasting effect.
Yeah, thank you. Thank you for sharing. So we're over time. Stephanie, you want to ask your question? Where'd you go? Maybe she had to leave. So Steve, you made a comment in the chat about you can't titrate down, which is why I love IVs, because you can slow down the infusion rate. But
Yeah, it wasn't really a question, but I've only worked with the trochees, and I actually do have a question now that I think of it. I've found that the patient themselves feel a little more controlled if they're putting it under their tongue or in their mouth. So especially when there's a little fear involved, I'll start as low as 25 milligrams with a trochee. But I was kind of joking. You can't titrate down. So we can go slow with that. Do you find that with intramuscular or IVs that the patient feels overwhelmed at times or uncertain about what's about to happen?
always. This is why Dr. Dave Dansky uses brain tap.
Mm.
As I mentioned earlier, then he says he doesn't have to use Versed. Yeah, Rob.
You know, I'm one of many people that that had a very difficult time with a 70 milligram IM injection. And I've seen in many training sessions, people have difficult times with it. So I have a real problem with the ability for people to consent with a single injection because the train has left the station, and sometimes people can
Yeah.
feel very damaged by that experience.
Mm,
And so first of all, I think the power and significance of a psycholytic experience, I think, is something that is underplayed by a lot of practitioners. So going with a troche and letting the patient feel comfortable spitting out when they're feeling like they're where they need to be.
hmm
I think a lot of people confuse a larger dose with a much better effect, and I'm not
hmm
that's really the case. So I
mm,
think less is more with a lot of patients. Really,
yeah.
it's depending on what you're trying to get to. So also, I think it's really important to think about a divided IM dose, which is a dose of like maybe 25 to 30 milligrams to allow the person to get into that space and get comfortable with it,
Mm,
and then give a secondary dose. And the patient is able to consent for that secondary dose. So
great.
I think the what I I'm not set up to do IV, and I think that is actually a really sweet way to do it because you really have very acute control over your dose all the way through that, and you're right there with the patient to see where they are at. But the I think IM sometimes can be damaging with that initial dose because you
Mm,
can't take it back.
yeah. Yeah. Thank you.
Yeah, that was the only time I was knocked out unconscious, and I did not like it at
Yeah.
all. I started to get paranoid, and then I was gone. I was knocked out. And that was a
Mhm.
55 milligram first shot.
I always want people to feel like they're driving the bus, like they're in the driver's seat and creating the experience.
Yeah, good
Thank you.
point. Okay. I know that there might have been a few more questions in the chat, and as Jenny said, I will get to them and answer the ones I can. I thank you all for hanging. Yeah, I really love the work that you do and your interest in this work. I will put a plug. If you're interested in going much, much deeper and taught by Ben Malcolm, the spirit pharmacist, and Dave Dansky, a very experienced ketamine doc out of California as well. Plus Angela Ward, a nurse that's been doing this work for more than 15 years. And I'm bringing in an attorney because we're talking about how to build a ketamine practice for palliative care. And so what you need to know from a regulatory standpoint and insurance standpoint. So that class starts May 11th, and it is a CME class, CME and CE class. But anyway, I thank you all. Good to see you, and have a great rest of your day.
Thank you.